My name is Tushar Trivedi. I'm a vascular neurologist. I'm also a stroke director at Regional Medical Center in South Carolina. Today, I'm going to share one of my research that I have previously worked on. The title is How Accurate Are Pre-Hospital Stroke Scales Used by Emergency Medical Services, and what are their clinical implications? What are their clinical implications? This is a state level experience from the data that we gathered for over a period of 4 years. These are my co-authors, and I do not have any conflict of interest or disclosures to report. So stroke is a medical emergency, right? A time is brain. Or after someone start having a stroke, for every minute that our treatment is not offered, almost like 1.3 billion neurons dies. Pre-hospital detection and triage are important components of a stroke care. Emergency medical services management of suspected stroke includes first performing a pre-hospital stroke assessment using different types of screening scores. Some commonly used screening skills in our state in South Carolina, which is in Southeast United States, include Cincinnati pre-hospital stroke skill and Los Angeles pre-hospital stroke skill. Second component is once stroke is identified, the EMS alerts the receiving hospital that they have a potential stroke case that they're bringing to the hospital. So I will briefly go over these two screening skills. I'm gonna focus for this presentation. The first one is the Cincinnati pre-hospital stroke skill. It's a pretty simple and straightforward stroke skill. It has 3 components. The score is given out of 3. If any one of the 3 is positive, a stroke alert is initiated. So the first one is, the first component is you check for the facial droop. If it's normal, you give a score of 0. If it's abnormal, you give a score of 1. The second component is you check for arm drift. You ask the patient to lift both arms up. And if you ask them to hold the arms for about 10 seconds, if it's normal, you give a 0 point. If it's abnormal, you give 1 point. And finally, you look for the speech. And in speech, you look for dysarthria as well as you look for language function. Is the patient able to get words out? Is the patient able to comprehend the speech? And you again give points for that. So any one of 3, if any one of 3 is positive, this will be a positive test. The second one is Los Angeles pre-hospital stroke skills, which is a little bit more detailed compared to Cincinnati pre-hospital stroke skill. You consider a few more clinical variables other than the exam itself. You look for the age. If age is 45 years or more, it is given a score. You look for the history of seizure or epilepsy. Since seizure before the presentation used to be a relative contraindication, this patient does not get a score for that. You look for the duration of the symptom. If symptoms are less than 24 hours, you do not get a score for that. If at baseline patient is not at wheelchair bound, or if patient is not wheelchair bound or bedridden, patient will get positive points for that. You look for the blood glucose. If it's less than 60 or 400 or above 400, you get negative score for that. And of course, you check for clinical exam. Again, you look for the facial symmetry, you look for the grip strength, and you look for arm strength. And based on all the clinical variables, a patient is said to have a positive or negative Los Angeles pre-hospital stroke scale. So what were the main objectives of our study? First was to evaluate the accuracy of Cincinnati pre-hospital stroke scale and Los Angeles pre-hospital stroke scale in identifying stroke cases in the field. And our second objective was to assess the impact of pre-hospital identification of ischemic stroke using Cincinnati pre-hospital stroke scale and Los Angeles pre-hospital stroke scale on treatment with IV TPA. I will briefly go over our main methods. So we got data from statewide EMS database and hospitalization records. And these were obtained from South Carolina Department of Health and Environmental Control. essentially for all, and the study duration was between 2010 and 2013. So essentially for these 4 years, for all the stroke cases that utilized EMS services, um, we got the data for that, and we merged it with hospitalization record from all the hospitals in South Carolina. So uh, this is more like a, you know, this is a uh, real life data, real life study. This is not a trial. We are actually getting for any patients who call EMS, their data is recorded. We have data for that. And anyone who is hospitalized, multiple variables are calculated. We have data for that. So we merge these two and utilize this data for our research. So during this study period, CPSS or labs was used for almost 90,000 cases. Results from EMS use of stroke scale compared with hospital discharge for stroke. So we used the database from that came from EMS utilization of stroke scale, merged it with the hospital discharge records, and we did some comparisons. So we checked for the accuracy of these stroke scales. We looked for sensitivity, specificity, positive predictive value, and negative predictive value. We also looked at the clinical implications. We also checked if someone is, accurately diagnosed with stroke using CPSS or labs, what's the impact of treatment of ischemic stroke with IVTPA? So these are our main results. So firstly, so we present selected characteristics of all stroke patients admitted in South Carolina hospital system who utilized who came either by EMS or they came by private vehicle. So overall, during this study period, we had around 56,000 patients, stroke patients. So these on the right side are the characteristics of patients who utilized EMS, and on the left side is for those who came by private vehicle. So at our numbers were at par with the national averages. We're around 1/3 of all stroke patients who arrived at the hospital use EMS, which is essentially, as a public health message, we like to more and more patients to use EMS rather than, especially with stroke, if they have stroke symptoms, then coming by a private vehicle. There were no significant differences in age between these two groups, no significant differences by gender or race. Something to note, which is clinically very, very important for any acute stroke case, the likelihood of them receiving IV-TPA, which is considered the gold standard of acute for treatment for acute stroke presenting in the first 4.5 hours, well, they were three times more likely to receive IV-TPA compared to those who were coming by private vehicles. The difference was 9% versus 3%, big difference. That's why it's highly encouraged for anyone, as a public health message, anyone with acute stroke symptoms should immediately call 911. So the EMS can arrive, can do a quick triage and take them to the right hospital where they can get the best treatment. So then we compared, the results of pre-hospital stroke scale with hospital discharge diagnosis. So the comparison was essentially, if in ambulance, a paramedic uses a stroke scale and they call it positive versus negative. If we compare this with the actual diagnosis on the chart, whether it's a stroke versus not a stroke, how accurate was the screening? So on the left side, you see the results for all the patients for whom CPSS was utilized. And on the right side, you see the result for all the patients for whom Los Angeles pre-hospital stroke scale was utilized. So we present the results of the sensitivity of the test, specificity of the test, positive predictive value, and negative predictive value. So going back to the definition, so sensitivity, right, is the ability of test to correctly identify patients with heart disease. So if a patient actually has a stroke, what's the probability that CPSS or labs would correctly identify them as having a stroke? So sensitivity for CPSS was 8%, and the sensitivity for labs was really poor, only 26%. And so someone with having an acute stroke, Los Angeles Free Stroke Scale was only able to correctly identify, mark them as positive only 26% of the time. Something very, very important to note. Specificity of the test, again, going back to the definition, is what's the probability of a test to correctly identify those does not have a disease. So specificity of CPSS was 95%, and for labs was 83%. So they were pretty very specific. They were able to correctly identify those who were not having a disease, but they did a very poor job in identifying patients with a disease with stroke. I also present results of positive predictive value, which again very poor, and negative predictive value, which were good. So again, recapping the main our findings, sensitivity was modest for CPSS, and it was very poor for Los Angeles Pre-Hospital Stroke Scale. Specificity was pretty good for both these tests. We also looked among those patients for whom we utilize CPSS or labs, what were the rates for IV TPA administration. So I will go a little bit more in detail for the slide because it carries a very important, it has very important implications. So on the left side, you're seeing all the patients for whom CPSS was utilized. And on the left side, in the orange bar, is the true positives. That means if CPSS said that the stroke scale is positive and they actually had the stroke, how many of these got TPA? On the right side, in the blue bar, you're seeing false negatives. So these people actually had a stroke, but the test was saying they're negative. So if the test is correctly identifying patients with stroke, that means they're true positive. For CPSS, there were 20% of people who received IVTPA was 20%. And same for labs, it was even higher, 33%. However, if for someone who had a stroke but test said it's negative, the probability of them receiving the standard of treatment, IVTPA, was pretty low, 3% only, 3.5%. For labs, it was a little bit higher, 14.5%. So the important message is if someone is having a stroke and the test is able to correctly identify, the EMS test is able, whatever stroke scale they're using, is able to correctly identify their probability of them as having stroke skill, having a stroke, then the probability of getting IVTP goes really high. So what were our main conclusions and recommendations? First, we found modest accuracy of CPSS and very low accuracy of labs in pre-hospital stroke identification. We found increased rate of IVTPA treatment for ischemic stroke when EMS surfaces were utilized and compared to those who were coming from private vehicles. Finally, early identification of potential stroke cases using CPSS or labs can have a significant impact on the treatment of stroke with IVTPA. The other recommendations that we would like to make based on our research. Firstly, it is really important to enhance the training of EMS staff to improve acute pre-hospital diagnosis of stroke skills. Even these tests are really good, but we need to make sure that our paramedics have proper training to utilize these tests. Second, we need to find some alternative methods of stroke screening that can be efficiently and used in the field, which can be efficiently used and also which are more accurate, right? So what we saw in our results, even though these tests are very simple and easy to perform, and but their accuracy, especially in terms of the sensitivity, was really, really poor. So we need some different stroke skills which can be correctly used is by which can be used with better accuracy in the fields. Over last few years, since especially last 3-4 years, a few new skills have come in the field. In South Carolina, there was a mandate made in 2018 where for all ambulances are using a stroke scale called RACE, which is a little bit more detailed and comprehensive compared to CPSS and labs. We do not have JIT level database to see how accurate is this new stroke scale. This is the next step of this research. We are currently collecting data for the last 4 or 5 years for all for the utilization of RACE stroke scale by EMS in South Carolina. And again, we'll be looking at the sensitivity and specificity, how good is this stroke scale called RACE in correctly identifying those patients with stroke. I think this was my last slide. It was again a pleasure making this presentation today. Of course, it's a virtual presentation, so I cannot take live questions, but if you have any follow-up questions, please feel free to email me on the following email address. Thank you so much.